Dr. Stuart Barr is a cardiologist and he is with Valley Medical Group Cardiac Services in Westwood. Very pleased to have him this evening. Thank you, Dr. Barr.
So, my name's Stuart Barr, and I am happy to talk to you about heart disease. The title initially said high blood pressure, but we'll do a little bit more than that. And then I'm going to talk about some of my favorite subjects, how we know whether things are right or wrong, and we'll talk about some of the fancy new technology that we have. And then I'd really very much like you to ask questions. Of course, now when I want to, there we go. Okay, start with a very general, easy. What is cardiovascular disease? So the big problem is a blockage from a fatty blockage that docs call atherosclerosis, right? All the doctor words are meant to be difficult, and so you just got to come up with them. Atherosclerosis, it narrows the blood vessel and restricts the blood flow and therefore the oxygen to your heart, or frankly, it could be to your brain, or people can have this problem in their leg. It really is, it can be a diffuse problem. And if they don't get oxygen, the cells die. And we call that a heart attack or a stroke, or sometimes someone's toe turns blue. It's all the same illness, all right? So this is just a cartoon of what we've been talking about. Sue, tell me, are they able to see my pointer?
Absolutely, yes.
Okay, very good, thank you. So this is a caricature of a blood vessel, and these little bumps and lumps here are these little deposits. That's why we all get all excited about cholesterol, because the underlying biology of this problem is that fat gets into the blood vessel wall, but it can't get out. And when it can't get out, it causes something that's called a foam cell, because when you look at it under the microscope, it looks like it's filled with foam, even though it's all fat. And then you get a reaction to those cells, and the artery is damaged. And that's what we call atherosclerosis. And then little by little, it encroaches on the lumen, we call it, the inside of the blood vessel. And we would say that this is what you've probably heard, perhaps a 60% blockage, maybe 70%. Okay, and the other thing to know about heart attacks is they don't occur because the blood vessel goes from 70% blocked to 80% blocked to 90% blocked to 100% blocked. That's in general not how it happens. The way it works is you have a 50% blockage, and that blockage cracks open. It ruptures, we call it. And when it ruptures, it exposes its contents to the bloodstream, like those fatty foam cells that we were talking about before. And what happens is the blood clots because of those foam cells. Okay. And that's why people can be healthy and jogging and feeling fine and die suddenly, is because you can get a blockage that goes from 50% to 100% in just a few minutes, because it's not about atherosclerosis as we see in this picture. It's about blood clotting as the end result of atherosclerosis. So obviously, it's the leading cause of death and disability in the United States and really all of the Western world. And when you consider that stroke is the number 3 cause of death, and that really they're the same illness in a different place, you realize that atherosclerosis and cardiovascular disease is far and away the leading killer, much more so than cancer, for instance. However, actually, we have made great strides in reducing the death from cardiovascular disease. And you can see that going from 1900 to 1970 or so, it was just a straight line up for cardiovascular death, partly because we became more sedentary, partly because our diets changed. I like to tell the story that when McDonald's went from animal fat in their fries to vegetable oil in their fries, that actually probably saved tens of thousands of lives. So we did better. And if you can see, there's just a little trend that actually it's getting even better now than it was. And that's probably because of advances in treatment, particularly the cholesterol medicines, right? The cholesterol medicines are amazingly effective in reducing your risk of cardiovascular disease. So the first thing I want to focus on is these risk factors for heart disease, of which hypertension is only one of them. And they sort of separate out into two groups. The first one are the ones you can't do anything about. My father had a heart attack at age 52 and died. We are not able to fix that just yet. There might come a time where we can actually manipulate those genes, but it's not probably going to be in my lifetime. So you have those kind of family history. The other things people say to me, oh, my dad had heart failure when he was 80. So that doesn't really give a younger person any additional risk. This is a rough one, but I tell people eventually everybody dies, and people who die of heart disease. So you can't use that as a judgment. Usually it's considered to be a man less than 55 and a woman less than 65. But of course, I mean, if somebody had a heart attack at 68, we would take that into concern. And then, of course, as you get older, your risk goes up. Nothing much we can do about that. Black people have a higher risk than white people. It's not 100% clear why. It's not just all societal factors. And gender, it's sort of interesting. Men have their heart attacks first because they don't have estrogen to protect them. And women have their heart attacks about 10 years later. The first hump for men is like 55 years old, whereas the first hump for women is about 65 years old. So those are the things you can't do anything about. But the things that you can do something about, and this is probably the meat of the whole thing, is to reduce your risk of heart disease. So we're going to go through them one by one. Smoking, you have to quit. Smoking is all bad things rolled into one: heart disease, emphysema, stroke, cancer. It's terrible. Very difficult to quit. Valley actually has a program now to try to help people quit. Very difficult, but something you got to do. Obesity is a risk factor for having a heart attack. And, once upon a time when I gave this lecture, I would say you got to eat less. But these new medications have taught us new things about being overweight. And when I first heard about Wegovy, I said to someone I know, well, they didn't have to be on that medicine forever. And that person turned around and said to me, but they're on their blood pressure medicines forever, and they're on their cholesterol medicines forever. So why can't they be on their obesity medicines forever? And I thought that was a very important point to change our thinking about obesity, which we used to consider a moral failing, but really it's not. There's some other thing that's going on. Activity, it turns out that the amount of activity that you need is something that everybody can do. 20 to 30 minutes of vigorous walking 5 days out of 7. Right. So people tend to think of themselves as if they were young and think that they have to be sort of gasping for air and pouring sweat to be exercising. Not true. You got to just go out after dinner and take a couple laps around the block. High blood pressure, it's one of those things that you have to have it checked. Right. So you have to get a monitor or go somewhere, or the CVS or whatever, your doctor's office. And the thing to know about blood pressure is that lower is better. So the current recommendations for most people is less than 140/90, but really 130 is better than that, and 120 is better than that. And when I say better, I mean lower risk of heart attack, lower risk of stroke, lower risk of congestive heart failure, those kinds of things. So serious things. So you have to get your blood pressure checked, and if it's high, you have to get it treated, get it down. It turns out that every 1 point, having your blood pressure go from 139 to 138 lowers your risk of stroke by 2%. Right? So you don't even have to get it all the way back to normal, but at least some. Diabetes is another blood test. You basically have to have a fasting sugar on one of your blood tests, which probably most people do routinely. That's a very complicated subject. Diabetes is very difficult also. And my patients who have heart disease and also have diabetes, I talk to them more about their hemoglobin A1C, the blood test for diabetes, than I do about their blood pressure. Because getting that number under control is very important for all kinds of things, your vision, just a whole lot of things. And then cholesterol, also a blood test. So here are the things that you can do to lower your future risk. So for smoking, I'm going to quit. There are some medicines that are helpful, by the way. The Nicorette stuff is, in my experience, not as successful as it was once hoped. But some of the medicines that are, sort of anxiety, depression type medicines, but help with craving have been helpful. And of course, avoiding secondhand smoke. So again, I would say this is an old slide, but it still matters, eating less. It's not, my joke about this is that if you have Haagen-Dazs all day and you only have 800 calories, you lose weight. Not that I'm recommending that diet. The diet I recommend is referred to as pesco-Mediterranean, fish and Mediterranean. You might have read that there's a whole lot of talk now about BMI, that maybe it's really not the best measure for overweight, and that maybe these waist circumference measurements, or because it turns out that where your obesity is matters a lot. And if it's all in your abdomen or all in your belly, that's worse than if it's all over your body. And of course, I have some muscular people who are just never going to have a BMI of 25 because they're just too big. But nevertheless, the overall thing of lower is better, which is true for blood pressure, it's true for sugar, and it's true for weight too. All right. And then because the cholesterol medicines are so effective and so potent, we sort of are a little less focused on this kind of stuff in the current day. I think that the major thing about what to eat is this whole business about processed foods. So salami and hot dogs are probably not great. Probably better off with like the turkey, and of course all the packaged stuff that has a lot of other things in it. Not to mention chicken is better than beef, and fish is better than chicken, and salmon's the best fish. Salmon and sardines. This is a slide that's probably depressing. I could tell you I do not personally have a BMI of 25, and it's a tough thing to get there. Oh, but I don't know if I have a slide of this. No. But the reason 25 is the number is that if you look at a graph of weight versus bad things, like heart attack and death and cancer and this and that, it kind of goes up slow. And then you get to, this is BMI at the bottom here. So here's your BMI of 21, 22, 23, 24. And then as soon as you get to 25, all of a sudden your risk of having something bad goes up. That's how that number got picked, even though it seems, somewhat on the lower side. Okay, so this is one of my favorite slides because I feel that my patients don't understand why we make the recommendations that we do. And so docs love this thing called a randomized controlled placebo study. And the idea of it is that if you take 1,000 people like you, pick a group, people in their 70s who have high blood pressure and a cholesterol more than 200. That's your group. You take 1,000 people like that and you close your eyes and you randomly pick 500 of them and you give them a pill. And the other 500 of them, you give them a placebo, a fake pill. Okay. And then you wait a couple of years and you count up how many people are alive. And if more people taking the medication are alive compared to the people who took the placebo, we think the medicine probably works. Right. And so all these things, when I say the blood pressure medicines make you live longer and the cholesterol medicines make you live longer, that's what I'm talking about. That studies have been done looking to compare taking the medicine versus not taking the medicine, or taking this medicine versus taking that medicine, to see which comes out better. And, it doesn't have to be death. The outcome could be heart attacks, or the outcome could be, how many days till the infection gets better, whatever, any outcome you could pick. But this is what doctors mean. And so when a doctor says that ivermectin doesn't cure COVID, this is what they're trying to say. They're trying to say that there's been no randomized trial to sort of say that this is something that works. So, and this is the same thing, frankly, with the vaccine. I'm sorry, I'm being just a teeny weeny, off base here, but this is the same thing with the vaccine. When you do a randomized trial of people giving them the placebo or the vaccine, more people with the vaccine live and they have fewer hospitalizations. And then there's something called the population study, which isn't near as good, where you look at 100,000 people and you see how many people have what, so it's a less precise thing because there's a lot of bias in that, but at least you can get some information. Okay, we talked about activity. Okay, the things that can help you. This slide is trying to tell us, what you can do to sort of help your blood pressure. Losing weight, which again, if you feel like you have 20 pounds to lose, just lose 5 and your blood pressure goes down. You don't have to lose every pound that you need to lose. lowering the sodium in your diet is helpful. It's not dramatic, but might make your blood pressure from 144 to 139, and that might be the difference between taking medicine and not taking medicine. You want to increase your activity. I talked to you about medicines for blood pressures greater than 140 over 90. But for instance, if you have diabetes, then the recommended blood pressure is less than 130 over 80, or any other high risk condition, such as diabetes. And then, of course, you don't want to have diabetes. You need a blood test, fasting glucose, less than, I would say less than 110. Okay. This is just a little picture telling you what we think of as the good numbers for cholesterol. I'll be honest with you, in my own practice, it's the LDL that is most focused on, low density lipoprotein. Sometimes people call it the bad cholesterol. And this is the number. If I was going to ask you to pick a number, this would be the number. Have the LDL less than 100 for most people, right? If you've had a stent, you want to do better than that. The current recommendation for people who have had bypass surgery is to have your LDL be 55 or less. That's a tough number to get to and takes a lot of medication. But studies have been done that show that the lower your cholesterol is, the more likely you are to live. Okay. Triglycerides, by the way, triglycerides are the only blood test that you have to have an overnight fast. For the other ones, it doesn't really matter. But triglycerides don't mean anything unless you've been starving yourself overnight. All right. And it's an independent risk factor. So if your cholesterol is good, but your triglycerides aren't good, that warrants treatment as well. Although the studies have not shown that treating the triglycerides is as effective as treating the cholesterol. Okay. We've talked about atherosclerosis, and we've talked about the risks for atherosclerosis and the things that you might do to help yourself not have atherosclerosis. Now, okay, we have a problem. I'm sure everybody's heard people say to me all the time, I've been doing this a long time, I'm not having any pain. I'm having pressure. And that's the typical thing. People say that all the time. So it's not that I'm having a pain in my chest. It's more pressure, tightness, heaviness, squeezing. My bra's too tight. There's a belt on, that kind of a thing. So pressure, tightness, heaviness. Sometimes it radiates into your left arm. Sometimes it radiates into your jaw. And that's really only because your body, you can tell when someone's touching you here and here, but your body can't really tell where things are going on. So there's nothing wrong with your jaw when it hurts. It's just that your brain's a little confused about the pain that's coming from your heart. Same thing with your arm. And then, of course, typically speaking, although not every time, coronary symptoms are exertional. Like I feel fine when I'm just sitting there, but when I try to climb the stairs, I get tightness in my chest. So, and then people often come in with what we call a crescendo of symptoms. So that before they were like, oh, I could walk 2 blocks before I really felt that feeling. Now I only go a half a block and I feel it, right? That's a typical story for heart disease. Then, and I'm sure you've heard, particularly in women, not everybody has the typical angina. By the way, angina is the Latin word for choking, right? So, because back when no one knew what anything was, people who had this feeling here felt like they were being choked. So anyway, that's what angina is. But men can have atypical symptoms too, but it's more common in women. And so that would be like fatigue, a little shortness of breath. A lot of people say that they thought it was indigestion. When you really have it, you're kind of like sweating all over. So there are other things. And, but all the people who have these kind of atypical symptoms, they do what I call, they feel bad. They know that something wrong is going on. I mean, you get a lot of people who are concerned about it and get evaluated and there's nothing wrong. But for the people who are actually having it, you can tell by looking at them that they're having it. All right, now this will briefly run through the risk of stroke, weakness or numbness. Strokes are almost always one side or the other. So it's either your left face or your right face, right hand, left hand. Sometimes people feel totally fine, but they can't quite get the words out. A lot of different kind of things, but these kind of neurologic, their coordination is off, that should make you think of it. And interestingly, just like we want to rush you into the hospital and open up that blood vessel that's blocked. Sorry, so participant is the name. Oh, someone's closed captioning. Sorry. When someone has a heart attack, we want to restore the blood flow to the heart muscle as fast as we can. And it's the same thing with stroke. So you'll sometimes hear the expression, time is brain. So if you feel like something might be going wrong, you can't wait until the next morning. You need to come in. And then I just threw it at the end here, peripheral vascular disease. Peripheral vascular disease, again, the same illness that you get in the carotid for strokes, the same illness you get in your coronaries for heart, you can get in your legs. And the symptom you get, docs call claudication. It's sort of a similar thing to angina. It's the feeling your muscle gives you when it wants more oxygen that it can't get. And usually people walk for 2 blocks and they get some cramping in their legs and they have to slow down or stop, and then they can walk again. Right. Time is muscle, time is brain. Okay, changing gears. So I just wanted to show you a couple of slides of the cool things we're doing at the hospital now. So when a typical problem, everything has a funny doctor name. This one's called aortic stenosis. So your heart has 4 chambers and 4 valves. And one of the valves, when the heart squeezes, this valve is supposed to open up to let the blood out. But sometimes as you get older, the valve kind of wears out because remember, it's opening and closing 60 or 70 or 80 times a minute since before you were born. So think how many times that valve is opened and closed. It's a lot. And so it wears out. And instead of opening up like this, it only opens up like this. So it wants to be like this, but it's only like this. So instead of there being a big hole for the blood to come out, the hole is too small. And then the heart has to work too hard to pump the blood through the small hole. And sometimes we have to fix that valve. So it used to be that we opened up your chest, opened up your heart, took out the old valve and put in a new one. But now we have this thing called TAVR, transaortic valve replacement. Trans means that's the way we go through. We go through your aorta, valve replacement, even though it's not really replacing the valve, it's implanting a valve. So this is the device. And so what you got here, I'm going to orient you. Your heart's down here. Your aorta is this thing up here. This is the main blood vessel that takes blood away from your heart. And like there's a blood vessel going to your right arm over here, and this blood vessel is going to your brain over here, and then your left arm over here, and then it kind of comes back down and goes down to your legs. These things are the coronary arteries. They're the arteries that feed the blood to the heart muscle, and they're the first blood vessels that come off the aorta. And this thing here is the aortic valve now that it's been fixed. And so even though the hole was too small, we went in there with an actual balloon, put the balloon into the blockage, blew up the balloon, and opened up the blockage. But it turns out that that doesn't last. So then we take the balloon out, and through your leg, we put a new valve. And the valve goes up on the inside and comes back, and we deploy it inside the old valve without having to open your chest. And people go home the next day. It's very impressive. So transaortic valve replacement, a treatment for aortic stenosis when the valve doesn't open. You take a balloon through your leg and open up the valve, and then you take another device and implant a new valve inside the old valve. Oops. Okay, this is another toy we have. It's called the mitral clip. The mitral valve is a different valve in the heart. It's built to open up to let the blood into the pumping chamber. And the idea of the mitral valve is that when the heart squeezes, this valve is supposed to close. So all the blood goes north and doesn't go backwards. But sometimes people can get leakiness of their valve. And when the heart squeezes, the valve opens up and the blood goes backwards, puts a stress on the heart. So lots of times, even today, we open up the chest and try to repair the valve. But the problem is that a lot of people who have this problem, this leaky heart valve problem, they're not candidates for surgery, right? They have too much emphysema or their kidneys or who knows what. But they're not good candidates to go to the operating room and have their chest open, right? So now you have this device that was developed just in the last few years called the mitral clip. And I told you that the valve has 2 things that flap open. Those things are called the leaflets that flap open and closed. And this device is, go backwards. Yeah. This device is built to grab one leaflet on this side and the other leaflet on the other side and stitch them together. And so it looks like this. You actually go in through somebody's leg. It's a little complicated, but here we go. You go through the right side of the heart, cross over to the left side of the heart, and then you have this device and you grab the two mitral valve leaflets. The leaflets have these little strings coming off them. You cinch them together, and it looks like this. And it doesn't remove it doesn't remove mitral regurgitation altogether, but people feel much better, and they didn't have to have their chest open. Mitral clip for mitral regurgitation. Sorry to say that this is one of my favorite slides. These issues are very difficult to talk to your family and your physician, but they're actually quite important. And so this first thing is a PULST. That's the New Jersey legal document called the Physician Order for Life-Sustaining Treatment. So you want your physician to know what it is that you want if the worst were to come to the worst, so we can honor your wishes when we're in the trenches. DNR means do not resuscitate. People have a little wrong idea about that, but it doesn't mean that we're not going to treat you. It doesn't mean that we're not going to try to make you better. It just means that if everything stops, maybe you don't want to end up waking up, if you do wake up, in the intensive care unit with a ventilator and cracked ribs from having chest compression, and then maybe you need total care for the rest of your life. Not saying that that always happens, but that's how we think about do not resuscitate. So it's something to think about. Comfort measures, comfort measures is one of those things that the truth is that sometimes there's no hope. And then you don't want to prolong the suffering. Those are very difficult conversations, obviously, and your family, your doctor, your minister or priest or rabbi or whatever, but they're very difficult. And hospice, and comfort. So comfort measures is we're not going to do active treatment. We're not going to give you more antibiotics, whatever, but we're going to make sure that you don't suffer. And we're actually pretty good at making sure you don't suffer. And then hospice is a philosophical approach, which is we've decided that aggressive medical treatment is no longer appropriate in the patient's best interest. Not we've decided, they've decided, like they've had enough. And so then that moves you in the direction of comfort measures. It's a lot of one from column A, two from column B kind of situations where it's a smorgasbord, and you could say, well, I want antibiotics. No, I don't want antibiotics, but I want fluid, and I want this, but I don't want that. But it's okay. You make the decisions that make you comfortable, right, and that align with your wishes. And the reason it's in capital about talk to your loved ones is people always tell me that they've filled out the form. And the truth is, I don't care that much about the form. It's important, but what's important is for the people who you love and who are in your life to know how you feel. Because I've been in a situation where a person has a clear living will saying they don't want anything done, leave them alone. And then their daughter comes and says, I want you to do everything. And it puts me in a tough spot, so having everybody on the same page is more important than any legal document. Okay. All right, let's see what time we are here. Oh, perfect, half hour. So in conclusion, remember that cardiovascular disease is the leading cause of death and disability, both in men and women by far. When you consider stroke and heart attack and really peripheral vascular disease is all the same illness. The next thing is to know what your risk factors are. So you got to get your blood pressure checked. You got to get some blood tests to make sure you don't have diabetes and find out what your cholesterol is and blah, blah, blah. And if you have some risk factors, you might consider modifying them, either with exercise or diet or medications or smoking cessation or whatever. And then, of course, I've tried to show you some of the symptoms that you might have if you develop some of these problems, and it's important to act properly. So I'm hoping that you have some questions. I ran through a lot of stuff pretty quickly. I'm perfectly happy for someone to say, I have a stent. What does that mean? Please ask.
Thank you so much, Dr. Barr. It was so comprehensive, and interesting and great reminders. Somebody was actually asking about low blood pressure. What would be a safe reading for someone with low blood pressure, and what are some of the concerns with that?
So here's what I say about low blood pressure. Low blood pressure is better, right? So to me, there's no blood pressure that's too low unless you're dizzy when you stand up, right? So a lot of young women, they walk around with 90/60 and they feel fine, right? So it's not the number itself. Some of my older folk, particularly like if you have Parkinson's or something, they're dizzy when their blood pressure is 110. You know what I mean? So it's a little bit variable, but I focus less on the number because lower is better. Remember, if you look at a graph of blood pressure versus bad things, the lower your blood pressure is, the better off you are. So lower is better. But if you get up to go to the bathroom in the middle of the night and you're dizzy and fall down and break your hip, that's not good. So that's my
Right.
take on low blood pressure.
Okay. Thank you. Um, oh, somebody wants to know the number for the Valley Smoking Cessation Group. I will get that to you.
I
Um,
don't know that one off the top.
you're right. Also, what someone has wants to know a little bit about your opinion about the home blood pressure kits. What are your feelings about that?
I think it's actually a good idea. The problem is two things. The
Hmm.
problem with home blood pressure kits is people are very psychiatric. And
Mm.
like checking your blood pressure 5 times a day, all week is just not helpful. It just
Right.
wigs you out and doesn't add to your medical care in any way. The other thing I'd say is you have to spend at least, let's just say $60 to get yourself a blood pressure cuff. Getting a
Hmm.
$20 wrist thing, not going to be helpful. But you don't have to get the ones with all the bells and whistles that cost $150 either.
Right.
I'm supposed to probably shouldn't plug brands, but Omron would be one that comes to my mind as, being a reliable one that's in that price range. And then you really
Hmm.
only want to check your blood pressure 3 times a week. Now maybe sometimes in the morning, sometimes at night. A couple other things about checking your blood pressure. You got to check your blood pressure with your arm on the table and your feet on the ground. And after you've been sitting there for a minute, you know what I mean? And the other thing about blood pressure is don't take your blood pressure in the morning before you take your medications, right? Because, of course, it's going to be high then. You want to
Hmm.
check your blood pressure an hour or two after your medications, or maybe at night, but not before the meds.
Okay. That's great. Someone is saying that they took a calcium test and results were high 2 years ago. Does the second one make sense now, or will it never decrease? 77 on meds. What do you think?
There's no point to get another coronary calcium score.
Hmm.
Calcium score, I mean, the number, has a statistical relationship to prognosis, but it's not significant. You have coronary artery disease. That means you got to be taking a cholesterol medicine, right? And doing all those things. You got to be more aggressive. I mean, the difference, I basically only order coronary calcium scores when I think you ought to be on a cholesterol medicine and you don't want to, and I'm trying to convince you to do it. But having a
Hmm.
second coronary calcium score, it's just going to make you upset and it's not going to change anything.
Okay, thank you. And another question was just, asking a little bit about in the last couple years, are there any medication trends or up-to-date treatments? Or, I know you gave us a lot of lifestyle information, but just wondering
Sure,
about that.
sure, sure. That's a good question, actually. So there's a couple, like there's now this injectable cholesterol medicine that you
Mm.
only have to take a shot twice a year.
Oh, wow.
So there's some of those kinds of things. We already have a cholesterol injection medicine like Repatha and Praluent that are excellent, if
Hmm.
the insurance company is willing to pay for it for whatever it is that you have. But there's a new non-statin pill called
Hmm.
Nexlizet that lowers cholesterol pretty much almost as good as the cholesterol medicines. It doesn't have that muscle ache side effect, so that's coming on.
Hmm.
And I have to say, from our perspective, these diabetes pills are heart
Hmm.
medicines now.
Yeah.
So if you have congestive heart failure, you're going to get that diabetes medicine, Farxiga or one of those. And if you have like heart disease and obesity, I'm thinking that I'm going to start giving you Wegovy, right?
Hmm.
Because the data is there. Remember, I told you about those randomized trials, so now you understand. So when you randomize obese people who have heart disease to Wegovy or not Wegovy, people who are on Wegovy, they live longer and have
Yeah.
fewer heart attacks, right?
And,
So those are the new treatments, like the diabetes type medicines. They're called SGLT1 inhibitors and GLP1 agonists, those two.
mhm.
And some of the new cholesterol medicines are really hot and sexy. And in my world, the other thing is those devices that I showed you. Every day they're coming out with some kind of new fancy device to fix this or that.
It's wonderful. It would just be wonderful if they could get the Wegovy type medications. Mounjaro is approved, not just
Right.
for, for weight loss more. It's really
Every
expensive and
medicine,
absorbent.
let me just
Hmm.
tell you, when I prescribe medications, I anticipate the insurance company is going to say no,
Hmm.
even if you have a good indication, and you have to fight. That's all there
Hmm.
is to it. That's the way the system is set up, that if you don't fight back, they're like, good, I don't have to pay for it.
Right, right. It's good. That's a good insight. Um, if you have, someone has a question, if you have good cholesterol, which puts you over the range for cholesterol, is that also bad? Like if you have a high score, but the good
High
cholesterol is
high
high.
HDL, that's the good cholesterol. High
Mm-hmm.
HDL is a negative risk factor, the opposite of a risk factor. It is a good thing to have,
Mm-hmm.
but that's why I try to focus on the LDL. So, I mean,
Mm-hmm.
if your HDL is 70, a pretty good number, but your LDL is 150, right? That's still probably not good enough.
Okay. And another question, I took a CTA a year
Yep.
ago, and
Mhm.
they want me to take it again. Is it really necessary?
That might be a little too in the weeds for me to be able to help you on that one, because
Mhm.
of course it would depend upon what the first CTA showed. Now, if you had a CTA and it showed whatever, mild blockage, moderate blockage, no blockage, severe blockage, you never needed to have any medical test repeated every year just because. That's one of the great scams, unfortunately, from my perspective. I'm a biased guy, right? But
Mhm.
nobody needs a test every year just because. So if you have a new symptom or a problem or they have a question, you're perfectly well within your rights to ask them, why are we doing a second test?
Okay. And let's see. Oh, can you talk about hyponatremia and heart disease?
Yes. So hyponatremia, that means low sodium in your blood test. This one's tough, so you got to pay attention. I don't even know who's
Mhm.
out there. Just remember that when I look at you, I can't see you. So hopefully you're listening. Um, Hyponatremia is a little hard to understand. Hyponatremia doesn't mean that your salt is low. Okay. I know that's odd. It means you have too much water. And what I'll explain by that is this. Just imagine that your body is a bag of salt water, right? Which is what it is. Your body's a bag of salt water. When you urinate out salt water. But when you drink fresh water. So just
Mhm.
imagine you have a bowl of salt water and you pour in fresh water. What do? You dilute the salt, right? And so low sodium in your blood is a dilution effect from having too much water, and the kidneys aren't fixing that. And the typical person who gets that is a person who's on a diuretic, like hydrochlorothiazide or furosemide or one of those chlorthalidone, one of those kind of pills. Because what happens is the diuretic medicines force the kidneys to behave in a certain way. And now they can't. So if I drink a lot of water, my urine kind of becomes dilute to get rid of that water. My kidneys kind of help me with that. But when you're on medicines, particularly diuretics, the kidneys kind of can't compensate. And so typically the treatment for low sodium is to restrict your water intake, right? Not to take more salt.
Thank you so much. Thank you just in general, Dr. Barr. It was so interesting and really very informative, very comprehensive.